Fantastic. So, well, good morning to Dr. Andrews, first and foremost, and good afternoon to most of you. It is my pleasure to introduce Dr. Andrews, who kindly accepted our invitation for today's seminar. So Dr. Andrews is a consultant medical oncologist at the Alfred Hospital in Melbourne, Australia, and he's also an early career fellow at Monash University. In terms of training, he has got basically pre-graduate training in immunology, biochemistry, and molecular biology. He completed his medical training at the Flinders University of South Australia and the Royal Melbourne Hospital. After gaining his medical qualifications in medical oncology in 2012, he completed a PhD in genomics and melanoma biology at the Olivia Newton-John Cancer Research Institute and the University of Melbourne, which was then followed by postdoctoral fellowship training at the University of Texas MD Anderson Cancer Center. This is where actually I had the pleasure of meeting Dr. Andrews for the first time. He is now a clinical lead for melanoma registry projects through the Personalized Oncology Division at the Walter and Eliza Hall Institute for Medical Research in Melbourne. He's also a clinical trial investigator at the Alfred Hospital and leads several clinical and biospecimen-driven translational research projects, evaluating the clinical outcomes, biomarkers, and fundamental biology of cancer therapies at Monash University. So obviously, Dr. Andrews is definitely one of the most qualified individuals I've met in the past few years, as well as one of the most brilliant minds I had the pleasure to meet. So it's a real delight to welcome him for this seminar. So Dr. Andrews, thanks for joining, and the mic is yours.
Thanks, Pierre. You'll make me blush with an introduction like that. So I'm going to talk a bit about where we're up to with biomarkers in cancer immunotherapy. And it's a bit of a cook's tour, I guess, in terms of the different kinds of biomarkers that we know something about. And it's also going to frame a discussion of the work that we published recently looking at biomarkers in the context of combined immune checkpoint blockade in melanoma. So thanks for the invitation. And also thanks for remembering it's morning here. These are my disclosures. For anyone who's a little bit geographically challenged, I guess, this is a terrible picture of the globe really, but Australia's down here on the bottom, and Melbourne is basically where that red arrow is pointing. So it's really down the bottom. And I would say that probably the key difference between our two countries at this point in time is this, not to rub it in, but you guys are freezing. And we are having a balmy 29 to 30 sort of degrees. Although I think the trade-off for this is the fact that it's 7 a.m. and probably my most important disclosure is that I am not a morning person. So I'll try to do my best and hopefully I don't have too many slides. Before I start, I'd like to acknowledge the original custodians of the land that I'm on today and pay my respects to the elders past, present and emerging. So by way of overview, I'm going to attempt to rapidly go over the developing landscape of cancer immunotherapy. I'll talk a bit about endpoints and some of their limitations on biomarker discovery as it is currently performed. And then we'll go through our little cook's tour of the factors influencing immunotherapy response, starting with genomic, then immune, and moving on to emerging, in particular the microbiome, which was the key area of interest for my postdoc lab. So I think the current audience is probably quite familiar with the fact that cancer immunotherapy is a big deal at the moment. And for many people, well, you know, although cancer immunotherapy as a discipline has been around for well over a century, I think it really hit the mainstream with the publication just over a decade ago of the seminal results showing improved overall survival in advanced melanoma patients treated with the anti-CTLA-4 agent ipilimumab. And it's really testament to the trialists involved in Jim Allison for really pushing for overall survival as the key endpoint in this trial. And since that time, we've seen rapid expansion in immunotherapy across different immunotherapy modalities, some of which are listed there. Across cancer types, I mean, there's scarcely a cancer type that hasn't been tried with immunotherapy to date. It's moving into earlier stages of disease, spanning curative and non-curative treatment intents. And the interest is well reflected in trial activity. So just searching the other day, clinicaltrials.gov, and looking even just at adult immunotherapy trials that are actively recruiting, there's well over 2,000. So there's a lot of activity. Some might say too much activity in this area. So endpoints in the immunotherapy era are an ongoing conversation. I think endpoints in general are often debated across cancer therapies. And we know that the gold standard is overall survival. And arguably, this is the most important endpoint if you want to publish your clinical trial result in the New England Journal. But for a variety of reasons, it isn't always practical or possible to assess overall survival or demonstrate an overall survival benefit. Frequently, that relates to patient cohort size, time required, and even finances. So we use a variety of other endpoints. And in the context of biomarker discovery, I think probably the most prevalently used endpoint is objective response, which is somewhat of a pseudo-objective measure. And so basically, this is a radiographic-based assessment of tumour burden. And we often depict this with waterfall plots, with upwards inflections indicating tumour growth and downwards inflections indicating tumour regression. Now, I always just describe this to the patient very simplistically and say what we want is for the cancer to go away. I'm happy if it shrinks. I'll accept if it at least remains stable. And what I really don't want is for it to progress. But in real life, it's not just about that number and that objective response rate. We also need to think about things like symptomatic benefit, functional preservation, quality of life, psychological distress. And there are some important caveats, such as reducing the burden of cancer doesn't necessarily make the patient healthier. Cancer shrinkage doesn't stay durably shrunk and doesn't always translate to a survival benefit. Many patients will have some tumour deposits grow and others regress. And formal progression, as per these assessment criteria, do not necessarily mean that the patient is deriving no benefit from the drug. So all in all, this is really making treatment decisions much more complicated, both to make and to explain to patients. And we compound that with the use of multimodality treatments, the fact that we treat patients beyond progression in many cases, and therefore are exposing patients to the risks of these drugs, the potential side effects for a longer period of time. There are also many other reasons for stopping other than disease progression. So to put this pictorially in the context of why I think this is relevant for biomarker discovery, I think we need to be conscious of what we're actually translating. We use objective response as a way to split patient cohorts and biospecimen cohorts into different groups and compare what's different between them. Now here we have two patients with metastatic melanoma, both of whom were treated with immunotherapy, and both of whom had a response. Now, the patient on the left, this is an FDG PET scan, has only 3 deposits, and you can see they've completely gone. This patient has a complete response. The patient on the right has much more widespread disease involving multiple visceral organs, and also has brain metastases, which you can't really appreciate on this scan. But again, impressive response. However, technically, by standard response criteria, this patient's had a partial response. And so in terms of biomarker discovery, the patient on the left will be weighted more highly, but I would strongly argue that I'm much more interested in understanding what has happened biologically in the patient on the right than the one on the left in terms of finding out what contributes to a good response. And it works the other way as well. So looking at patients who progress, again, 2 patients, advanced melanoma, treated with immunotherapy, both of whom have progressive disease. Now, the patient on the left has very small scattered deposits, mostly soft tissue, and some of them have increased in size, and there are some new nodal deposits appearing, particularly in the groin. The patient on the right, I think you don't have to be a clinician to see that this is clearly a terrible outcome. And indeed, it really is. However, both of these patients from biomarker discovery and response assessment point of view are equivalent. They're both simply progressive disease. So I think we need to be very conscious about how we are defining our endpoints, because I think they're really going to impact the power with which we can discover new and useful biomarkers. Now, another issue is that in attempting to improve the responses to immunotherapies, we're increasingly trialling combinations. And this comes with some risk. So we know from the 067 data, looking at the prototypical immunotherapy combination, ipilimumab and nivolumab, that certainly in terms of multiple sort of endpoints, we do see improvement, at least numerically, and to varying degrees of statistical significance when you combine these agents rather than giving them as monotherapy. However, the cost of this is a substantial increase in the rate of high-grade toxicity. So it reminds us that biomarkers really need to be able to address both response and toxicity, at least separately, if not simultaneously. And as an aside, I think we've seen some very encouraging preliminary data from the anti-PD-1 and anti-LAG3 combination, which shows, again, improvements, early data, but improvements in survival outcomes with comparatively less cost in terms of increased toxicity. So that is very much a case of watch that space. We also know that immunotherapy is increasingly being rolled out into earlier stages of disease. So we've got 3 key trials in melanoma looking at adjuvant immunotherapy with improvements in various types of survival to date for the anti-PD-1 agents, not for overall survival, but that's another story. And even earlier still, we see that preclinical models are now emerging. Early clinical data suggests that the neoadjuvant approach may in fact be even more superior to adjuvant, at least in certain clinical cohorts. So there are several clinical challenges that I see as motivating biomarker discovery. We want to improve response rate, we want to improve the durability of our responses, and we want to mitigate toxicity. And identifying biomarkers that can tell us something about these 3 things can then itself drive the discovery through further translational research of potential new targets and hopefully lead to potential new therapies. Now, what do we already know in terms of the biomarker space? So I like to look at the factors influencing immunotherapeutic response, starting with the tumour cells and the tumour microenvironment, and then taking a zoom out approach to look more broadly across the patient and even beyond. Much has already been shown in terms of particular factors that are associated with good or bad immunotherapy response when looking at tumour cell features or tumour microenvironment features, some of which are sort of listed on the right there. And I'll cover these a little bit more in coming slides. So if we start with the tumour cell, we know that tumour mutational burden is one of the things that has most often been spoken about. And mutational signatures such as UV and smoking, to some extent, really act as surrogates for an underlying higher tumour mutational burden. Driver genes in and of themselves don't necessarily contribute to good or bad immunotherapy responses, but certainly there is, we typically find a lower overall tumour mutational burden in cancers that have a key oncogenic driver. We know that mismatch repair enzyme deficiency can lead to a higher accumulation of mutations over time. And again, acting as a surrogate for higher tumour mutational burden is a histology agnostic marker of likely response to at least anti-PD-1 immunotherapy. And there are some more immunomodulatory events, some specific genomic events that have strategic relevant effects on immunotherapy response, or indeed just cancer immunity in general. And these include mutations in beta-2 microglobulin and JAK molecules that lead to a reduced immune visibility, I guess. Beta-catenin overexpression can lead to immune exclusion from the tumour microenvironment. And there's a long-standing literature in terms of heterogeneous antigen expression, which can lead to partial but incomplete immune clearance of cancer deposits. Looking more particularly at the clinical utility of tumour mutation burden, hopefully you can see this, it's a little bit small, I do apologise, but we know from, there have been quite a few studies on small cell lung cancer, which are very useful in looking at this. And firstly, we know that estimating TMB from a targeted next-gen sequencing panel very well approximates that as measured by whole exome sequencing. So from a clinical application point of view, it's certainly feasible. But when you look at a couple of cohorts, as this study did, of lung cancer patients, the patients who derived clinical benefit from immunotherapy, shown here in blue or the grey boxes, relative to the other boxes, Yes, there is a trend for a higher TMB in some of these patients, but the majority of them really overlap. And so this does not perform particularly well as a biomarker for clinical application. You can see that comparing mutational burden in blue with PD-L1 expression in JCO's delightful, weird yellow color, it actually underperforms predictive power of a PD-L1 simple stain on its own. And if you combine these two metrics together in a binarized fashion to make a 2x2 sort of table, whilst you can enrich for identification of clinical benefits in the double positive population, and then you do enrich for the non-responders in the double negative population, as you can see overall, this performance is not very good, and there is clear contamination in all groups evaluated. In terms of survival outcomes, we've also shown in non-small cell lung cancer studies that a high non-synonymous mutation burden and a high transversion burden, which is really a mutational signature that acts effectively as a surrogate for much the same thing, are both associated with an improved progression-free survival. And even in overall survival, excuse me, this is true with patients with a high TMB using an appropriate threshold, do appear to have an improved overall survival. However, this is not statistically significant. It is important to note that the patients who have this sufficiently high TMB are clearly the minority, and to a large extent, that probably led to this analysis at least being underpowered. Now, mutation-based signatures of various flavors have been tested, as I say, quite extensively. So a key anti-PD-1 treated cohort that was published several years ago showed similarly that a non-synonymous single nucleotide variant burden trended higher in responders versus non-responders to anti-PD-1, but this was not clinically significant, largely due to this phenomenon of substantial overlap between the two groups. Other derivative or associated metrics such as neoantigen burden paralleled that finding, but they did find that the top tertile of TMB was probably prognostic more than anything else for overall survival, with a trend also seen in TCGA, which of course is a varied cohort that largely or completely was not treated with anti-PD-1. Hence, I say it's probably more prognostic than predictive as such. So in general, TMB is inadequate, certainly on its own. It has been published that a neoepitope signature, which obviously the neoepitopes are derived from the mutations present in a particular tumour. And this study found that a neoepitope signature itself was actually associated with long-term benefits from immunotherapy. And you can see this up here on the right, where we've got the training set above and the validation set below. To my eyes, it looks somewhat surprising that there seems to be such a high proportion of shared public neoepitopes when you consider the sparse diversity of individual mutational events that you see in any cohort. And it's also quite interesting to note that the shared public nature of these neoepitopes is substantially less in the validation set. So it's fair to say, I think this hasn't really made it into the clinic either. Probably of more interest is modelling tumour cell genomic and T cell clonal dynamics simultaneously, as was suggested to Riaz. And I probably don't really have time to explain this too much, but focusing on the green line, which is the responder patients, what they showed is that there is an association between T cell clonal expansion and the loss of clonal mutations in the tumours. So there's really parallel evolution of both cancer cells and infiltrating immune populations, consistent with the notion of epitope pruning, basically. So we looked at the predictors of response and toxicity to combined immunotherapy checkpoint blockade in melanoma patients, as this has been somewhat less studied than the context of monotherapies. And we took a cohort of stage 3 and 4 melanoma patients treated with ipilimumab plus an anti-PD-1 agent, either nivolumab or pembrolizumab. And this was essentially a retrospective cohort, standard of care. Some patients were treated on clinical trials as part of their own standards of care. But very much a pragmatic cohort where we took available biospecimens of various types, pre, on, and post-treatment, and analysed both by response and also development of high-grade toxicity, being grade 3 as per CTCAE or lower. And we subjected these to a variety of different analytical platforms for biomarker discovery. So I'll start first with the molecular and immune profiling. And initially starting with tumor genomic factors. So we looked at mutation burden across this cohort, and more specifically, we looked at a cohort of genes that are frequently dysregulated in cancer, a cohort of genes that are involved in interferon gamma signaling and antigen processing. And as I mentioned before, it's really a sparse and diverse set of mutational events that you see in this tumor type. And we really didn't find any particular recurrent genomic differences or alterations in specific genes when comparing the responders on the left in blue and the non-responders on the right in red. And I think one thing to notice is, of course, that this combined immune checkpoint regimen, at least in melanoma, is highly active. So, of course, we have a skewed distribution in terms of responders versus non-responder numbers. When looking at the overall mutational burden, yes, as others have shown, there is certainly a trend for higher levels of TMB in patients who had better response. However, this was not statistically significant. And you can again see, obviously, it would be more easier to see on a logarithmic scale, but most patients, regardless of their response status, still had this overlapping quantity of mutational burden. And a derivative from the mutational data is this neoantigen data, which is in silico prediction of neoantigens based on the known mutations. And looking at the strong binding neoantigens, again, there is a trend for a high number of strong binding neoantigens, which are presumably some of which will be immunogenic and likely contribute to response. But again, the majority of patients have this overlapping low level, and thus it's not very useful from a clinical point of view as being discriminatory of response or non-response. Looking at copy number variation, again, we compared responders and non-responders, and this time did find that there was actually an excess burden of copy number losses, specifically in the non-responding patients, shown here in the box whisker plot, where you can see high levels of copy number loss burden in the non-responders, and these copy number alterations were particularly evident on chromosomes 5, 10, and 15. Now, immunomodulatory factors are many, and these have been studied to a great extent, particularly in melanoma, but across other cancer types as well. I see this as a dynamic competition between immune attack and escape, and from the cancer cell's point of view, it really comes down to a balance between how visible a cancer cell is to the immune system and how susceptible it is to immune killing. So we've spoken about some of the cancer cell intrinsic factors that weigh into this, such as mutational load, neoantigen burden, and antigen presentation machinery defects, all of which I think really contribute to how visible a cancer cell is to the immune system. But we know that the immune susceptibility is also very important. The flavour of immune skewing, whether it's Th1, Th2, or even Th17, is certainly relevant to how effective an anti-cancer immune response may be. It's important to have the right T cells that recognise the antigens that are actually being expressed. And we know that inflammation within the tumour microenvironment can alter the antigen processing machinery and actually change the antigens being presented and potentially lead to a degree of T cell repertoire mismatch. Obviously, immune checkpoint molecule upregulation is one of basically the place where this mostly started. And PD-L1 expression is clearly of value in some clinical situations more so than others as a predictive tool and use in the clinic for treatment selection. We've spoken a little bit about strategic, as it were, genomic events such as PTEN loss, some beta-catenin activation, and alterations to antigen processing machinery. We also know that there are some signatures that I'll talk about a little bit more, and it's not just about T cells. So there's a lot of interest, particularly in myeloid-derived suppressor cells, and also other myeloid populations. One of the key findings really in the space of immune biomarkers is that the dynamics of the immune biomarkers also matter. Probably not surprising in hindsight, but here you can see some melanoma tumours stained for a variety of immune markers. And at the pre-treatment time point, comparing non-responders on the top line to responders below, there's clearly some difference in terms of T-cell markers, but overall it's fairly bland. Whereas following the initiation of immunotherapy treatment, there is an absolutely striking difference between the non-responder on the top and the responder on the bottom. And it turns out that this is actually quite diverse in terms of the immune infiltrate. So again, factoring into the limitations of our biomarker discovery pipeline, are we or are we not measuring things at the right time in order to be able to discover what we need to discover? Now, this immune biomarker dynamicity is also evident in the neoadjuvant setting, where we found in a trial of neoadjuvant Nivo or Ipi-Nivo, responders to treatment in their on-treatment biopsy had significant upregulation of quite a diverse range of immune markers in their tumour microenvironment, here measured by a multiplex nanostring platform. So we looked at the tumoral infiltrates in our patient cohort of combination immune checkpoint blockade, and as expected, we found high levels of CD8 T cells within the tumours of responder patients, which was nearly significant, but again, there's a substantial number of patients who have an overlapping low level that's non-discriminatory. Associated with this was a high level of PD-1 expression in tumours of responder patients, which suggests that these patients are more appropriately poised to respond to PD-1 blockade. Now, interestingly, we also found high levels of CD4 and FOXP3 as a marker of Tregs in responder patients. And this is not to suggest that the combination checkpoint blockade necessarily depletes Tregs, as there is ongoing debate as to whether this is, in fact, an effect, particularly of ipilimumab or not in humans. But it may suggest that the efficacy of reactivation or priming of naive T cells that we see with combination checkpoint blockade is strong enough to overcome a Treg suppressed microenvironment. We also found that higher levels of entropy of the infiltrating T cell repertoire were associated with response. Now, tumoral gene signatures, coming back to this, have been used quite extensively as a method of effectively summarizing the tumour microenvironment and having a quick look at everything that's there in combination to see whether it's favourable or unfavourable from an immunotherapy point of view. So from the anti-PD-1 cohort I described earlier, they developed the innate PD-1 resistant signature called IPRES, which is actually a meta-signature. So it's a signature of signatures of largely things to do with epithelial mesenchymal transition, some wound healing, angiogenesis. And essentially they found that upregulation of this meta-signature of 26 signatures was a characteristic of non-responding patients to anti-PD-1 and a low score on this IPRES, so basically non-enrichment of the meta-signature was found in the responder patients. It's a spectrum, so if you look at an unselected cohort of samples, you will find a range from low to high scores on the IPRES. It's not related to BRAF mutation presence or absence specifically, but it is questionable whether it is actually related to response. Certainly, if you look at other cohorts that have also applied it, you found that basically you see the entire spectrum from low to high IPRES scores within each response category, suggesting that it actually is not reproducibly related to response. Now, there are many other tumoral gene signatures, such as T-cell infiltration, function and dysfunction scores, as implemented in the Riaz paper, shortly after the previous one, which discovered IPRES. There's an IMPRES score, so an immunopredictive score, I think is what it's called, which is essentially a checkpoint co-association model, which was trained, interestingly, on neuroblastoma. There's a T-cell exclusion signature, melanocytic plasticity signature derived from comparing two sensitive versus two resistant genetically engineered mouse models. So, you know, the list goes on and on and on. And I think as a group, they're limited by external validity and also clinical applicability in terms of how practical it is to use these and whether it really performs better than a single PD-L1 stain, which in many cases they don't. So returning back to our overview diagram, we've looked at some factors arising in the tumour cells and the tumour microenvironment. And what we're increasingly realising is that the systemic immune system or systemic immune tone is actually very important to what's going on in the tumour microenvironment. Some great data published in Cell in 2017, where Spitzer and colleagues had showed that pharmacological prevention of lymphoid egress from secondary lymphoid tissues essentially completely ablated response to anti-PD-1 therapy in this colon cancer model, which is normally very responsive to anti-PD-1. So you can see in blue is the anti-PD-1 treated, and green or red, which are lying almost entirely on top of each other, are anti-PD-1, are either untreated or anti-PD-1 with blocked lymphocyte trafficking. And importantly, also in that study, they found that it's not just about CD8 T cells. Our evaluation of immuno-oncology has been very CD8 T cell centric, but CD4 T cells also want to be part of the party. And they found this activated CD4 T cell population, which itself, if given as adoptive transfer into a breast cancer model, was highly efficacious in inducing tumour control. We had studied some differences in the peripheral immune compartment in the context of both monotherapy and combination immune checkpoint blockade. This work was led by Spencer Way and Jim Allison's lab. And some of the key differences really with these two populations here: an activated terminally differentiated effector CD8 T cell and a Th1-like CD4 T cell. So similar to what you saw on the previous slide, both of which seem to be particularly strongly increased in frequency following combination compared with either monotherapy, and both of which act to contribute to tumour cell destruction. In our combination checkpoint cohort, I was particularly interested in peripheral immune populations and toxicity, because the toxicity is more of a systemic compartment phenomenon, as is the peripheral blood. So we found that the T cell repertoire diversity was higher in patients who developed high-grade toxicity. And there was evidence of high-level T cell clonal expansion in some patients who developed high-grade toxicity, which is similar to a finding in prostate cancer from several years earlier. There was also evidence of a higher T cell proliferative index in the patients who developed a high-grade toxicity. And all of these results are really speaking towards a potentially greater activation of autoreactive T cell repertoire, a latent autoreactive T cell repertoire, leading to the manifestation of clinical toxicity. And going back to our summary again, now that we've zoomed out to the systemic immune compartment, if we zoom out further, we actually are increasingly understanding that the environment or environmental factors affecting the host are relevant to cancer immunity and immunotherapy response. And in particular here, I'm talking about microbiota. We know from various isolated studies that microbes can impact on components across all four of these areas, but it's fair to say that at this point in time, we still have a very, very early understanding of what's going on here and how these elements link together. Now, microbes have been implicated in essentially virtually all facets of human health, spanning cardiovascular disease, mental and neurodevelopmental health, skin diseases, allergy, as well as having obvious effects in the gut in terms of drug and nutrient metabolism and absorption. Unsurprisingly, microbes have also been implicated in cancer, and most particularly for the cancer types shown on the right, most of which are gastrointestinal system areas where the burden of microbes is high and closely opposed to the actual tissue in which the cancer arises. So that intuitively makes sense. Now, the question of how microbiota influence immunity is big, and needless to say, we don't really have much time to go into the details of that, but it's also fair to say that at this point in time, much of this remains fairly unknown. We know that the microbes are wherever they are now, whether that's in the gut, which is the largest microbial community present in or on a human body, or in the tumour, because we're also understanding that anatomical sites we previously thought were sterile actually aren't. So there is a tumour microbiome, there's a normal tissue microbiome. So wherever these microbes are, they can cause local inflammation. They can produce carcinogenic compounds or epigenetic modifier compounds, and they can lead to immune priming locally. That can be innate through pattern receptors, or it can be of adaptive responses in a pathogen-specific manner. Now, these effects can then disseminate locally and to draining lymph nodes, and thereby lead to priming of other immune cells. The compounds that they produce locally can be absorbed systemically. And so all of these things can then influence immune cells at distant sites, which exert potentially anti-cancer or indeed toxicity effects at distant sites as well. We know that gut microbiota are clearly relevant to clinical cancer outcomes in patients. This is probably best described in the context of allogeneic bone marrow transplantation for leukemia, where it's been clearly shown that a high diversity of the gut microbiota is associated with an improved overall survival following transplant compared with lower levels of diversity. In the context of solid cancers, the greatest existing body of evidence is in colorectal cancer, which, as I said before, makes sense because the tumor arises essentially directly in contact with a heavy microbial load in the colon. And one of the key bacteria implicated in this is Fusobacterium. So Fusobacterium itself is generally a low abundance organism, but it is actually quite prevalent or enriched in colorectal cancer tissues. And interestingly, it's been found to, whether it travels with or colonizes post hoc, but it certainly is also found in colorectal cancer metastases at distant sites. Fusobacterium contributes to chemoresistance, and it's also been shown to have immunosuppressive effects. So it provides very compelling evidence that the gut microbiota are relevant to cancer immunity. So we studied the oral and gut microbiome in metastatic melanoma patients starting systemic therapy. And this work was led by our excellent colleague, Deepak Gopalakrishnan. And essentially, it was a large cohort of melanoma patients who went on to have biospecimen sampling, including the oral and gut microbiome. There was a variety of different treatments within this cohort. And so for the purposes of this analysis, we focused on the largest sub-cohort, which was shown in blue in the pie charts, which was anti-PD-1 treatment. So again, the biospecimens available were subjected to a variety of analytical panels for biomarker discovery. And as expected, we found that a high diversity of the gut microbiota was associated with improved progression-free survival in this cohort compared with lower levels of diversity. Responder patients had a relative enrichment with Clostridial species at the expense of Bacteroidea, which were enriched in non-responder patients. And even at the single genus level, Faecalibacterium on its own, when present at high abundance cut at the median, was also associated with improved progression-free survival compared with low abundance. We examined the tumour microenvironments of available samples in this cohort and found higher CD8 T cell densities in the tumours of responding patients. Now, the CD8 densities were directly proportional to Faecalibacterium in the gut and inversely proportional to the Bacteroidetes abundance. When looking at the diversity of the immune infiltrates by Faecalibacterium or Bacteroidetes abundance, we found that high Faecalibacterium and essentially responder patient tumours had high levels of immune infiltration, and this immune infiltrate was quite diverse, including lymphoid cells and myeloid cells. By contrast, the high Bacteroidetes non-responder patients had a very bleak and bland picture in their tumours. And looking in some of our mouse models where we gave responder patient or non-responder patient fecal microbial transplant to the animals prior to initiating anti-PD-1 therapy, responder FMT was associated with high levels of innate effectors in the tumour and lower levels of suppressive myeloid cells, which again goes to the point that this is not just about T cells, and in fact, it's not even just about lymphocytes. It appears to be a whole immune system response at play here. So other groups have looked at the similar associations in the context of epithelial tumours. and had shown that antibiotic exposure around the time of initiating anti-PD-1 or anti-PD-L1 therapy was associated with an inferior overall survival. And again, in lung cancer and melanoma cancer models, using FMT from responder or non-responder patients given to mice prior to initiation of immunotherapy, mice that received FMT from responder patients had better overall responses, here in the triangles or here in the red lines, than those that had received FMT from non-responder patients. So again, we looked at the microbiome in our combination immune checkpoint blockade cohort, and we looked at both response and toxicity using a combination of patient data and mouse models. So starting with response first, we showed in our mouse models that microbial differences prior to treatment are associated with the eventual outcome as to whether mice ended up tumor-bearing or tumor-free at endpoint. And while the effect on response was less dependent on the overall diversity of the gut microbiota, there were still particular species that mattered in terms of response. Here showing high level of Parabacteroides dustostonis as being associated with response in our patient cohort. In terms of toxicity, we found that the gut toxicity does depend on the microbiota. There is some variation between mouse models and site along the gastrointestinal tract, but certainly antibiotic ablation of the gut microbiota is able to reduce the evident toxicity. And this was dependent on interleukin-1 receptor signaling, within both models, interleukin-1 receptor blockade significantly reducing, almost ablating gut toxicity. Importantly, IL-1 receptor 1 blockade reduces this toxicity without compromising response. And it's the role for interleukin-1 beta in gut toxicity is also implicated in human samples when measured in the colonic tissue of patients experiencing colitis versus a normal cohort. So looking more specifically at individual taxa associated with outcome, here with toxicity, our most toxicity associated bug was Bacteroides intestinalis. And indeed, in the mouse models, if you supplement the gut microbiota with Bacteroides intestinalis directly, you get more gut toxicity. This was associated with high levels of interleukin-1 beta. And even giving a fecal microbial transplant from a patient that contained high levels of Bacteroides intestinalis to begin with, compared with lower levels, you also get elevated levels of interleukin-1 beta in the gut. So we've shown, and I think there's enough data now to make a very compelling argument that the microbiota influence cancer immunity and specifically influence immunotherapy response. The question arises how you modulate that therapeutically. The most established mechanism is fecal microbial transplant, which we know is already used in clinical situations such as Clostridium difficile toxicity, colitis, I should say, and IBD. And this is a technique where we're trying to make the recipient's microbiota look more like a favorable donor microbiome. You can also give defined microbial consortia where you know exactly what's in there, assuming that you can identify a group of microbes that you think are conveying the majority of the effect. Probably the most applicable, widely speaking, globally speaking method is diet and supplementary modification as a way to alter the composition of the microflora. And alternatively, we can also try to deplete detrimental microbiomes by various strategies, including targeted antibiotic use or bacteriophages. Now, it's important to understand that this is not just fantasy at this point in time. All of these things are actively under investigation and have been shown to be potentially beneficial either for anti-cancer response, for the treatment of severe toxicity. And what's also very interesting is more recent discovery and description of the human tumor microbiome and the very tantalizing possibility that there are specific microbes within cancer types that we can target directly. And so to summarize, I think in terms of the what's new in the biomarker space, specifically talking about the microbial biomarkers. So we are identifying microbial predictors. There are some recurring taxa across studies, including Faecalibacterium, Ruminococcus, Akkermansia, and Bifidobacterium. But unfortunately, there's no perfect overlap, and it's not clear whether this represents variation between the cohorts being studied, cultural and dietary variation between the geographic locations where these cohorts were sampled, or whether individual taxa are really not the answer, and maybe it's the overall picture, the community level structure that's more important. So we know that a higher alpha diversity of the gut microbiota is at least associated with response to anti-PD-1 monotherapy, but perhaps the diversity association in the context of the more active combination checkpoint blockade is not the same. We need to work out whether single taxa are relevant, or groups of taxa, or if in fact it's the metabolites that they produce, which are in fact the key element here. And these, the details will be important in determining how best to manipulate the microbiome and how to choose the right donor if we're looking at fecal microbial transplant strategies. So Chris Spencer from our previous group at MD Anderson had recently published some very interesting data looking at lifestyle factors and diet. But I think at this point in time, although I get asked this fairly regularly by my patients in terms of what they should do for their diet, should they take probiotics or not, it's probably too early to advise, but it would be nice to be able to have a hard evidence-based answer to provide them in the near future. In terms of therapeutic development, so microbial products or their biochemical capabilities, we need to work out which is the most practical to use as a therapeutic target or a therapeutic agent. And as I said, I think this field of the intratumoral microbiota is really very interesting in terms of cancer development and also as a potential therapeutic target. Harking back to what I'd said much earlier, I think biomarkers of toxicity are equally important and are clearly lagging behind our biomarkers of response. And I think this is also reflected to some extent in the funding schemes, which typically it's much harder to get money to support a study of toxicity only, and it really needs to be paired with response. But I would argue that we do actually have some very active regimens that we often aren't comfortable to give to patients because we're concerned about the toxicity. So I think it's still a very relevant goal to mitigate the toxicity without necessarily increasing the response of the drugs that we already have. And so existing biomarkers are obviously not without limitations. I think everything that I've discussed today, other than perhaps PD-L1 expression in certain cancer contexts, really hasn't made it into the clinic. In order to get these features beyond the research space and into the clinic, I think we need to develop some composite metrics that are actually going to be predictive without being heavily contaminated by a large number of patients for whom there is no discriminatory value. So with that, I'd like to acknowledge former members of the WAGO lab, in particular, Sonia Deepak Gopalakrishnan and Jen Wago as the leader of the group, where basically all of this data came from. And we had some vital collaborations across the organisation with the medical oncology and surgical oncology and pathology teams. And also I'd like to acknowledge Laurence Zifogel and her group in France, and Connie. Interestingly, Connie, my co-first author on that paper, is also Australian and moved back to Australia about the same time as me to the same city, which is quite remarkable, a remarkable coincidence. And with that, we'll take any questions.
Thank you so much, Dr. Andrews, for this very compelling presentation. Perhaps we can open up the floor for questions.